Hi guys, welcome to DOCSHAALA. So in our rapid revision series of Mission MDS, we are going to start with oral medicine and radiology. So we'll just revise bacterial infections. This is Dr. Janvi and let's just revise bacterial infections in a go. So coming to the bacterial infections, we are going to see four types of infections here. That is MF, periapical lesions, odontogenic abscesses, Ludwig's angina. So we'll also discuss MCQs one by one in this series. So be glued and be attentive to answer the MCQs. Okay. So what is MF? It is also known as Vincent's angina, French mouth, Vincent's stomatitis, necrotizing ulcerative periodontitis. So the etiology is gram-negative anaerobic bacterial infection, especially Bacteroides fragilis, and gram-positive. So gram-positive organisms such as Fusobacterium nucleatum. So the predisposing factors include poor oral hygiene, smoking, stress, malnutrition, systemic conditions like HIV and AIDS. So what is ANAC? Acute necrotizing ulcerative gingivitis. Yes. So let's just see the other factors here. So the clinical features, this is the main important slide. The clinical features include painful bleeding gums, bright red, swollen, and easily bleed on touch. Okay. So you have to remember this. And the necrotic ulcerations. The necrotic ulcerations are like crater-like ulcerations with very pseudomembrane covering. This is a very important and very commonly asked in the questions. Okay, the foul odor is present, regional lymphadenopathy is seen, and systemic symptoms include fever, malaise, and occasionally leukocytosis. Okay, then the treatment. The treatment, as you all know, first of all, we have to maintain a proper oral hygiene of the patient. The patient should be advised with proper oral hygiene, scaling and root planing, and antibiotics. When coming to antibiotics, the most common antibiotics used in ANAC are metronidazole or amoxicillin combination and penicillin. Okay, these are the most commonly used antibiotics in ANAC. So the symptomatic relief, we give pain relievers and some topical anesthetics. And the most important point here is we do not use steroid combinations in ANAC. This is because these steroid combinations, if they are used, they worsen the case. Okay, because ANAC is seen in immunocompromised individuals, right? When we are using it in when we are seeing it in immunocompromised individuals, when the steroids are used on them, they don't have the capacity to fight with steroids. Okay, so the because of already compromised immune system, the steroids do not work here and they worsen the case. So this is a very important point which you have to make note of. And the complications include secondary infections, gingival recession, and periodontal attachment loss. Then coming to the pictures, so you can see the pictures here. This is early stage of ANAC, and this is the late stage of ANAC, advanced stage. And this is the, what is this? Guess what is this? This is microscopic image. Microscopic image. Okay, microscopic image, which is dark field microscopy. Dark field microscopy is used in ANAC, which shows spirochetes. Okay, the histopathological examination, that is the microbiological examination, what we use in ANAC is dark field microscopy, where it shows spirochetes. This is one more important point which you need to be aware of. And so let's just see a question around Anand now. So a 20-year-old male presents with painful bleeding gums, fetid breath, and swollen cervical lymph nodes. Intraoral examination reveals multiple punched out ulcers at the gray pseudomembrane on the interdental papillae. Which of the following findings on panoramic radiograph is the most suggestive of panic? So we didn't see the radiographic features, but we will see in this with this question. So the options they gave are extensive horizontal bone loss around multiple teeth, vertical bone loss with furcation involvement in molars, then interproximal alveolar bone resorption, particularly interdentally, and periapical radiolucencies around several teeth. So with the knowledge you have till now, just think what the answer can be. But we'll discuss this question also. So coming to the radiographic features that we see in MX. So first thing is we see extensive horizontal bone loss. Okay, it is most commonly associated because this in MX we see chronic periodontitis lesions. So this is seen and vertical bone loss with furcation involvement. Vertical bone loss with furcation involvement, especially in the molars, is also seen in the MX. And interproximal alveolar bone resorption, particularly interdentally. So you can see the same in the image. Interproximal bone loss is seen in the OPG here, right? Interdentally. So this is the suggestive finding of anal because infection primarily targets the interdental papilla. So the infection in anal primarily targets the interdental papilla. So the interproximal alveolar resorption is seen. And periapical radiolucencies, if there are associated apical abscess or cysts around the tooth, then only it is seen. Okay, horizontal bone loss seen in chronic periodontitis. Okay, and vertical bone loss with furcation involvement, especially class, is seen in advanced periodontitis. It is not seen in early stage of NF. Okay, so the diagnostic feature we can see in the OPG is interproximal alveolar bone resorption, particularly interdentally. Okay, so this is the diagnostic image we can see in annex. So the answer for the question in the previous slide will be most suggestive will be interproximal alveolar bone resorption, mostly, particularly interdentally. So this will be the answer for this. Okay, I hope you are clear with Anand now. Okay, let's move on. Let's move on to periapical lesions. The periapical lesions which we are going to see is the areas, the radiolucent areas which are present in the apex of a tooth. So what does they indicate? They indicate inflammation or infection of pulp and periradicular tissues. So this is very important. So periapical lesions, whenever you see a lesion like this in the apex, it is involved with pulp and periradicular tissues. So the etiology can be pulp necrosis, apical periodontitis, and sometimes trauma, cysts, tumors, and foreign bodies may also be associated with this. Okay, so this you have to remember. Then, coming to the types of periapical lesions that we have acute apical periodontitis, chronic apical periodontitis. The acute apical periodontitis will be sudden onset of pain, swelling, tenderness in the affected tooth. The radiograph will show a small radiolucency at the apex. Then chronic, which is a painless and it slowly grows. Okay, it is of three types: periapical granuloma, radicular cyst, periapical abscess. The granuloma will be small, well-defined radiolucent area with a distinct border. Granuloma will be small, well-defined radiolucent area with a distinct border. Then radicular cyst, which will be larger, unilocular or multilocular with irregular border. Okay, larger, unilocular or multilocular with irregular border. Then periapical abscess. The abscess will be a fluid-filled cavity with ill-defined borders, which can cause swelling and pain. So this slide is very important as a differential diagnosis of the various periapical lesions that we see in the oral cavity. Okay, take a note of this slide. Then coming to the images. So with the description that I have given before, you can make out the images now. So the first image. So it is showing a small lesion here. So it can be what? Acute condition, right? Then you can see a distinct border in this case. This can be the, what is it? Periapical granuloma. Okay, right. Then coming to this. This is larger. It can be multilocular or unilocular. So this is periapical. Come on, I'm waiting for the answers. Periapical. It is a radicular cyst, right? So this is a radicular cyst. Then coming to this. So you can see the border is ill-defined. There is no particular border. It seems like it is just going and fusing with the bone. So this is seen in abscess conditions. So this all you should remember. So this is the radicular cyst. So this is also a very important slide now. Please make a note of it. This is periapical granuloma. And this is acute apical periodontitis. Okay, so this slide is very important. You have to make note of this slide. Okay, then coming to the treatment. So you know the treatment, right? First of all, we have to give endodontic therapy. If the cyst is larger, we can go with incision and drainage. Okay, and antibiotics are prescribed. Okay, so let's see a question around this. A 35-year-old woman presents with mild discomfort on biting in the upper right second premolar. Radiographic examination reveals a well-defined round radial recency at the apex of the tooth with a distinct border. So this here itself you have the answer, right? Well-defined round radial recency, apex of tooth, distinct border. There are no signs of swelling or tenderness on clinical examination. What is the most likely diagnosis? I will not do not see the options. Just try to answer from this. Well-defined round radial recency apex of the tooth with distinct border. It is periapical granuloma. Okay. Even without radiograph, you can answer this now, right? So you have to prepare like this. Okay. Then odontogenic abscesses. The odontogenic abscesses are abscess. Abscess is collection of pus. The collection of pus which is arising from infected dental pulp or periradicular tissue it gives rise to odontogenic abscess. Okay. So etiology, bacterial infection. The types include periapical abscess, which we have seen already, then periodontal abscess, which develops near the gingival margin of the tooth root, and gingival abscess, which is a superficial infection which is confined to the gingival tissues. So, since we have seen this already, we will go with periodontal abscess and gingival abscess now. So, the periodontal abscess is a collection of pus that forms in the gum tissues due to bacterial infections. Poor oral hygiene, accumulation of plaque, calculus can lead to inflammation and infection of the gum tissue around the tooth. The symptoms include painful red, swollen gums that bleed easily, tenderness on bite or touch. This is a very important thing. And throbbing pain. Throbbing pain sometimes radiating to the adjacent epithelial periodontal abscess. And there is foul odor, purulent discharge in severe cases. Sting. So we have two types, acute periodontal abscess and chronic periodontal abscess. Acute periodontal abscess which develops rapidly with intense pain and swelling. So this is the acute periodontal abscess. So sometimes it may be seen on the radiograph or it may not be seen on the radiograph. Then chronic periodontal abscess which grows slowly and less obvious symptoms but often mistaken as a gum disease. So as you can see, there is a sinus tract discharging in this image, which is a chronic periodontal abscess. You can see the type of bone loss that has occurred here, right? Then coming to the antibiotics that we can give. So the main thing is, first of all, oral hygiene, scaling, incision and drainage of the cyst. If the cyst is large, we have to do incision and drainage. Then give antibiotic regimen to the patient. So giving pulpal therapy depends. If it is an endoperioral lesion, we'll go for RCT. If it is not an endoperioral lesion, there is no need of RCT with antibiotic regimen and proper oral hygiene practice and drainage of pus itself relieves the symptoms and regenerates the tissue around the tooth. Okay, so when it is acute periodontal abscess, we use amoxicillin. So amoxicillin with a loading dose of 1 gram and by maintenance dose of 500 milligrams twice daily is given for 3 days. Okay, and when allergy to beta-lactam drugs, we go with azithromycin or clindamycin. Right? Then coming to gingival abscess. So gingival abscess is a localized accumulation of pus within the gum tissue only. Okay. So the symptoms here also resemble that of the periodontal abscess, but the only thing is there will not be any bone loss in gingival abscess. Okay, the infection is localized only in the gum tissue. It is also of two types, acute gingival abscess which develops rapidly and involves only single tooth, and chronic gingival abscess which grows slowly and with obvious symptoms and is often mistaken as a gum disease but involves multiple teeth. Okay, so this you have to remember. So let's go with the question now. A 25-year-old man presents with facial swelling and throbbing pain. Throbbing pain is seen in two conditions. One is periodontal abscess, the other is gingival abscess in the upper right jaw. So examination reveals a red, swollen, tender area above the maxillary canal with purulent discharge from the gingival margin. Radiographs show periapical radiolucency around the canine root and no radiographic evidence of the bone loss around other teeth. That means only canine is involved in here. So which type of odontogenic abscess is most likely present? Since it is showing the condition that it is a periodontal abscess because we have a evidence of periapical radiolucency determining the bone loss. We should go with periodontal abscess, right? So I have two more bonus questions for you. Just make a note of these questions. Okay, I'll keep these questions in the comment box also below and just answer these questions. Okay, so this is very important, like differential diagnosis of these three abscesses, periapical, periodontal, and gingival. So it's based on these. Okay, then Ludwig's angina. So this is one of my favorite image. So this represents the double tongue appearance that we see in Ludwig's angina, right? So why we get like double tongue appearance in Ludwig's angina is because the infection is spread in three spaces. What are those spaces? That is submandibular, sublingual, and submental spaces. Okay. Since the infection is spread in three spaces, we can see this double time appearance in Ludwig's angina. We also have a video of Ludwig's angina. So for detailed explanation, you can go and watch that video also. Okay. So we'll see a brief here. So it is a severe bacterial infection of floor of the mouth. Okay, often starts from abscess wounds or mouth injury, rapidly spread to several surrounding tissues, including neck and jaw. The symptoms include sudden onset of pain, swelling of floor of mouth and neck. Difficulty in swallowing and speaking is there. Speaking sounds like a hot potato in the mouth. Drooling may be seen. Fever, chills, and difficulty in breathing is seen due to airway obstruction in severe cases. Then, coming to the complications. The complications include airway obstruction and death if not treated properly. So, first of all, when we see a Ludwig's angina patient, we have to make sure that the airway is competent and then give the other treatment. So, here we have to follow the ABC rule. Okay, airway, breathing, everything we have to check first. Then sepsis, tissue damage and scarring. So emergency, first of all, airway management and intubation if needed, antibiotics to fight the infection, and incision and drainage to release the pus. Okay. Then, coming to the question, a 35-year-old man presents to the emergency department with a 2-day history of severe swelling under his tongue. There is difficulty of swallowing, drooling, and a muffled voice. He has a fever of 1 or 2 degrees Fahrenheit and appears distressed. Examination reveals diffuse swelling of the sublingual, submandibular, and submental spaces. So, as already told you, if the inflammation swelling is involving these spaces with elevation of tongue and mild fever and stridor, if the most likely diagnosis will be Ludwig's angina. Okay, so the answer will be Ludwig's angina for this case. So I hope you have understood the bacterial infections. This is just a rapid review, and I hope this will help you for the exam. So all the best.